Hello and welcome to Reimagining Risk. It's a new podcast that asks people to think differently about things when it comes to risk management. I am pleased to say alongside me is Dr. Will Taylor. He's the Chief Medical Officer of the Herefordshire and Worcestershire ICB. And I've also got Dr. Clare Marley, Improvement Director for the ICB as well. So I've got some big hitters. We're going to be okay, gang. How are we? Are we well?
Very well, thank you.
Excellent.
Good, thanks, Jim.
Right, okay, so I suppose the place we start is, why are we here? Why are we doing this podcast?
We're here because I think we all recognise that our healthcare systems sometimes do not serve our patients as well as they could do. We're seeing that in our urgent and emergency care systems, where patients are having long waits in A&E, having corridor care, and sometimes coming into hospital when it's not always the most appropriate place for them to be. And we questioned, why is that happening? And one of the things we wanted to look at is, why are clinicians making the decisions they do? Why are clinicians sometimes making decisions that are more about their own risk and not always about the risk of the patient in front of them? And then thinking about how we can support clinicians to do this better in the context of the whole healthcare system.
And I think it's fair to say, isn't it, Will, that you and I are so passionate about
Yes.
that patient-centred decision-making
Yes.
and working as a system to support clinicians to share that risk so that we're acting in the best interests of the patient rather than letting risk affect the decisions that we make about patients that then may lead to harm.
Yeah.
And I think really important to highlight that our decisions about individual patients not only affect that patient in front of us, but they affect other patients in the system. So, for example, every avoidable or unnecessary hospital admission potentially causes harm to 4 people. So it's that person that ends up in hospital getting care that they don't need, and the potential harms of infections, DVTs, PEs, that person then that's stuck in the ED corridor getting care in the wrong place, the patient that potentially is waiting outside the ambulance to get the care that they need. But actually the patients that are the most risk then is that patient stuck out in the community at home that's getting no care at all. So I think we're really good. We all want to do the best for the patients that are in front of us, but actually it's those patients across the whole system. And we've got to work together to make sure we're thinking about all of those patients to reduce harm for all.
And I think this has been something that's been a passion of mine for a while. And I'm very lucky. I'm as well as being a practicing GP, so I see how this affects my patients on a daily basis. I'm also the vice chair of the West Midlands Clinical Senate, and we had a number of clinical fellows at the Senate. And one of the things we set the fellows, and they did this fantastic piece of work where they actually went and did an appreciative inquiry piece of work with a load of clinicians in their trust, looking at why clinicians made the decisions they did for patients. And they produced a fantastic paper, which has been published on the Midlands Clinical Senate website if anyone wants to go and have a look at it, looking at this. And it was really interesting in that the findings they had really resonated. People make decisions about patient risk, and they will often do that with a little bit of fear of complaints and fear of litigation. And the things they said would actually help them make better decisions wasn't rocket science. It really wasn't rocket science. It's stuff we'll all know. It's about having a cohesive team around them that supports them. It's about having visible senior clinical leadership that's there for them and they can access and go to. It's about understanding and trusting the resources around them, particularly the resources outside their organisation. So if you're in a hospital, trusting that the community be there if you discharge a patient back into it and be able to manage that. And we wanted to take that and then see, right, how do we apply this practically?
Yeah, and how do we support every clinician at each transition point of care to manage that risk, to have those conversations?
It's all about supporting the clinician, isn't it? To
Absolutely.
make the best decisions that then best supports the patient.
So what's the problem then? What's happening that are making healthcare professionals approach things with a slightly more risk-averse nature?
We are seeing more and more people in hospital in the last years of life, or actually we are seeing people in care settings that are perhaps not the most appropriate place for them. And I don't know if you wanted to just elaborate on that, because that is the root thing we're seeing here. that we then want to address.
So it's sort of audits looking into patients that have been conveyed to an ED department, but actually when you look at the notes, it's not always in their best interest. And if they use an alternative pathway in the community, that may have been actually what they wanted. But patients aren't always asked about what they wanted. And I think we're all very good, aren't we, at devising sort of going for national best practice or looking at different pathways and policies. But often these pathways are condition specific. So, for example, the patient's had a head injury, so they go on this pathway because they need a CT scan. But I think, what could we do actually if we think about what matters to the patient rather than what's the matter with the patient? So instead of having condition-specific pathways, we have patient-specific pathways.
That's a really interesting distinction, isn't it?
Yes.
And that is right at the heart of patient-centric care.
Yeah.
Absolutely.
And we often admit people to hospitals because the perception is the hospital is the safest place for them.
Yes.
Whereas actually we know that it often isn't. Patients become disabled in hospitals. Patients become deconditioned in hospitals, and that actually often causes more harm than we are solving.
So people are playing safe almost.
So,
end up in hospital, there's the mental and physical deterioration, risk of onboard infections, those sorts of things.
So the question was, why is that happening? And this comes then back to your point, is what are we then trying to address?
Yeah. And I think some of the audits that we've done have shown that actually clinicians, particularly paramedics, are wanting to keep people in their own care setting at home where they're most comfortable, but actually they're having difficulty accessing those pathways or accessing other clinicians to have conversations with, to manage those risks. So it's about sort of breaking down those barriers to be able to access those out of hospital
but also give them permission to challenge. So it was a lovely story that came out in some of the workshops we've done around this about a patient who had her blood done. Fairly routine thing. Blood came back to the GP, had a hemoglobin of 4.5, I think it was. Really, really anemic. Quite scarily anemic, actually. And I can understand that GP immediately went, right, we need to get this patient into hospital. The ambulance turned up because 999 were called. The patient was watering her garden. The ambulance then took this patient, who was fine, into hospital. So this anemia had obviously been building over some time. They weren't acutely unwell. Obviously came into hospital, went through triage, sat waiting then to be seen till 12 o'clock at night. 12 o'clock at night, patient obviously fine, got admitted into a hospital bed, then stayed into the hospital the next day where they had an iron infusion. At a number of points during that time, that elderly patient could have been changed. The GP could have gone, well, actually, yes, that's a scarily low blood hemoglobin, but actually the patient is fine. This can wait till tomorrow. I can get them in a more routine basis to that iron infusion. The pathways probably aren't there to support that, though. So actually, we need to engineer those pathways into the system, allow that GP to do that easily and have confidence in them. The paramedics could have come in and gone, well, actually, I've got some discretion here. I can see the patient and they're fine, but I don't feel I can challenge the GP. So where do we allow people that permission to do that?
And actually going back to what we said at the beginning, Will, what about having the conversation with the patient and the patient empowerment? So yes, this is your hemoglobin. The options are you could go in hospital today or you could go in tomorrow, and these are the risks.
True,
I think we're very good, aren't we, when patients come into hospital for operations, for consenting them for all the risks. But do we do it enough when patients are facing a hospital admission? Because we know the risks are there, but we often say, well, this could be dangerous, you need to go into hospital.
You're talking about the problems, why it's important as healthcare professionals to change their approach in managing risk. So how do we go about doing that?
So there is something there. So there's something there about experience. Because actually, we talk about the patient's risk and understanding the patient's risk and patient-centered. We also have to understand the feelings and motivations behind the person who is the clinicians that are making those decisions, their own fears, their own experience, their own background, the adverse event that happened to them 2 years ago in a similar situation, which then influenced their decision making. It should be about bravery. It should be about saying to the person making that decision, there's someone seeing you can go and talk to this. Actually, you've got a wider team you can consult with. You're not sure about something. Let's think about it around. Or you've got this patient in front of you with low hemoglobin. They look fine. They're saying they don't want to go into hospital. You've made that decision. You can consult someone in the hospital and say, I've got this patient. I think they need to come in, and someone else will go, yeah, actually, I can sort that out for you. And you've got confidence that will happen.
Yeah.
It's about having the teams. It's about having the senior clinical leadership that then wraps around you to help your decision making.
And about sharing that risk with the patients themselves. And actually, having recently had a conversation with paramedics, the family are really important here, aren't they?
Yeah.
Because often, the family comes in, they're really understandably worried about a relative, but actually they're not, again, themselves aware of the risks. And I think this is particularly important for our frailty cohort, isn't it?
Yeah.
Previously as a frailty GP, I've seen firsthand the harm that can come to patients, increased confusion in hospital, but just having those really honest and open, transparent conversations with the family as well.
That's really lovely, because actually it plays into that conversation we had, didn't it? About there's 3 places you address this. You address this with a patient-centered approach, but we also need to understand the clinician-centered approach. So how do you address this as patient-centered? Also addressing the issues that clinicians have as individuals, and then at organisational level.
Absolutely.
The fact that a number of organisations will actually manage their own risk, the risk of CQC, reputational risk and things like that, often very individually as well, without consulting the whole system. So there's almost 3 levels we need to address this at.
And then how do we communicate risk between all of those organisations? So a patient example was a patient was discharged from the surgical team. The surgical team had written in the discharge letter to say this patient, if they deteriorate, will not be suitable for readmission and surgical procedure. But then there was no communication to the community teams around that. So that patient deteriorated again, had an ambulance and an unnecessary admission. So again, it's that communication between the different organisations.
So actually what you two are talking about is this is a cultural shift, isn't it?
Absolutely.
And so when you mention collaboration, for a cultural shift to work, it needs the buy-in of everybody and the self-esteem of everybody to be able to make those decisions. So be honest with me here. How realistic is this?
This is not going to be easy. We're addressing a culture in the NHS that has moved to a degree, not in everybody, I'm not saying this is endemic, but to a very risk-averse, defensive way of practicing medicine. And also to a degree to a taskification of things. So, a nursing home may see a patient deteriorating. Right, my task is to call an ambulance. The ambulance turns up and goes, well, my task is to take this patient to hospital. The patient turns up to hospital, sees a junior member of staff, goes, well, it's my task to order a load of bloods and x-rays. By the time they see someone senior enough to make a decision, they've already gone through all those tasks, and then it's late at night and they get admitted. Let's start thinking about putting the patient first, asking us, why am I doing this at every single stage? And saying, is this best for the patient? And then talking to the patient about that and saying, this is where we are, but is this best for you? And yes, that's going to be a huge cultural shift. It's a cultural shift thinking about, how effective is the team that's around you?
But I think
how
at our
effective is
recent risk workshop that we had, Will, I think everybody across the system was bought into this, and actually it needs to be everybody's business. Everyone's passionate. They want to do the right things for the patients. They want to have patient-centred decision making, but it's those barriers that we need to try and break down.
What amazed me at that risk workshop was how much this resonated, because we had a risk workshop where we invited care homes, we invited ambulance staff, we invited GPs, community nursing, we invited people from across the professional spectrum, so as physios, OTs, as well as sort of doctors from the front line and ward staff. This resonated with everybody. Everyone said, and everyone has stories where this was going wrong.
And I think it was centred around patient stories, which is why we're doing this, why we're here. I think the other thing that's really important for me is that proactive escalation planning. So when you were saying, Jim, why does this happen? What's the issue here? Often these are clinicians trying to make these decisions under highly pressurised circumstances. You might be out in the community in a care home 6 o'clock at night. You've not got access to many investigations, for example. So actually, if we make sure we communicate that risk early, we know that risk is there, and we sit and have these conversations with patients and families when we're not under that pressure before they actually deteriorate, which goes back to the work we've been doing around respect wording, quality advanced care planning.
So you're looking at the person rather than trying to lean too heavily on the process. But I mean, could you understand why people might be risk averse?
I mean, any clinician who's going through this thing will have seen things where they've got stuff wrong. And that, and had complaints and had, potential things that's hanging over there. It makes you scared for your livelihood. And sometimes that will drive your decision making. But the other thing that I think, and you alluded to this, Claire, around pressure, is that you become much, much more risk averse in your decision making when you're under pressure. So when the A&E is busy, when you've got a really pressured clinic, when you know you've got 5 people sitting outside your consulting room, you actually start making more risk averse decisions. And that's because you're trying to defend yourself and probably trying to defend the patient. But what we know then sometimes is that risk averse decision making is not always in the patient's best interests. And that's where you need that patient.
I think there was a really good quote, wasn't there, that we mentioned at the workshop, that if we as clinicians risk nothing, then our patients risk everything.
Yeah,
so
absolutely.
It's remembering the impact.
And a risk averse decision making is not always risk averse for patients. It actually may increase patient harm, especially if you're putting people in hospital, as we mentioned earlier, unnecessary, where actually we should be looking at keeping them in their home. Home is often the best place for patients, especially when they're frail.
And I think sometimes we often think as clinicians that we have to do something. We're trained to help, aren't we? We must do something. There must be, but actually realising it's okay to do nothing sometimes, and watching and waiting and sharing that risk with the patient and the family, that's okay too.
So that's interesting. I've not really thought about that. I mean, as doctors, you want to fix things, you want to fix people. And so that natural human instinct as well. You've got this message then for people who are making the initial decisions about how they approach risk. And we've also been talking a little bit about culture, and then that sort of sits with management. It sort of sits with the level above, and it's almost like you're asking for an environment, work environment that encourages those decisions.
I think we need to address a number of changes that have happened in the NHS over the last few decades, where hospitals have lost some of their team structure, partly through shift work and partly things. And I understand why it's happened, but it means that cohesive team approach has often been lost. Your go-to senior clinical leader who you trust is not always there. But also that communication and understanding between organisations, between systems. So, if you're a physiotherapist doing a discharge, do you know and understand and trust the physiotherapist in the community, and actually trust them to take up some of the things you would normally assess before discharge and say, well, actually, I know the team in the community. They'll sort out the stairs and they'll sort out all these other bits and I know and trust that. So I can let this patient out a few days earlier, back into their own home, back into their safe space, because I trust the services in the community and I understand the services in the community.
And actually, if I let that patient out a few days earlier, that patient that's outside ED waiting the ambulance can get in to get the care that they need. So that understanding that their actions will impact other patients.
What can we do to help those professionals make less risk-averse decisions and more patient-centric ones?
So I think this is really important. And this is about starting to make this conversation. So when we talk about risk in healthcare systems, we normally have lots and lots of meetings where we bring organisations together at chief execs and say, right, how's your organisation managing risk? And what we aren't doing is often addressing the people who are making those decisions and why they're making those decisions, and talking to the people, and also bringing the patients into that conversation as well. So what do we need to do? It's going to be a huge piece of work, I think, around talking to teams, understanding team cohesiveness, raising awareness of the rule of 4. So the decision about the person in front of you affects 4 other people. Making sure people feel that their team has their back. That's really, really important. But not just your team has your back, the teams around you that support you has your back. I think there's a little bit of understanding about, does that then exist? And staff surveys that we have within the NHS suggest that it doesn't always, and it could be better. So then there's a piece of work about, understanding the why, then understanding what do we do about it? How do we rebuild those teams? How do we build that confidence? How do we make sure that senior clinical leadership is there? How do we enable people to have the time in pressured situations to have really good conversations with the patients, to understand the patient's context and the patient's needs and the patient's wants, but also to communicate with them the risk of being admitted to hospital in the same way that we would communicate routinely to a patient the risk of having an operation.
Absolutely.
So they can make really confident decisions about their own care.
And I think there's something for me in our roles as well, Will, in terms of that system bit of making sure we've got easily accessible, trusted pathways to get access to senior clinical decision-making support.
Yeah, and trusted pathways into the, and this then, it goes into a number of other pieces of work that we've been looking at. So there's a little bit about professional standards, how do professionals work together, how are people civil to each other, how do they all do that? But also, and I think this is possibly one of the most important things that's happening at the moment, is the piece of work around neighbourhoods. So if you want someone to not go into hospital unnecessarily, you have to have confidence that the services in the neighbourhood work. They are integrated. The patient in their home is going to have as good care, if not better care, because it's their own home. Their place, their home, where they recognise it's where their family are.
And those teams know their patients, they know them well, they know their families.
Yeah, and it's all going to wrap around them. And it's going to be, better care than hospitals. And also, families often perceive the hospital to be the place that's the most safe for their elderly relative. It's often not. No. But it's about changing those perceptions that the family will go, actually, my elderly mum's poorly. She's at home, but that's okay. Because this person is coming in, they're looking after her, and they're getting excellent care. So it's almost changing perceptions of clinicians, family, the public, patients to really understand that works. And the neighbourhood work, making services in the community for that population, for that community, really does work for them and then wraps around them and holds the patient in the best place for them for that piece of care.
And then clinicians working across organisational boundaries. Yeah. So actually acute clinicians picking up the phone and talking to our community neighbourhood team clinicians as well. Like I spoke about earlier, just sharing that risk communicating the risk between them.
Yeah. So the neighbourhood team will be a group of clinicians from multiple organisations, but actually they will work for that population, that 30 to 50,000 population community. And their team will not be the organisation they work for. It'll be the group of people they work for in that 30 to 50,000 population and communicate with each other and work in an integrated way. And that's then your cohesive team that allows you to do this piece of work. And I think we need to integrate this message into the building of the neighbourhood teams.
And I think we're planning on working on a decision support tool to help some of this as well, aren't we? All just based on some of the principles we've been talking about, which will support our clinicians.
Well, you see, this is where I was going next. This podcast is called Reimagining Risk, and that is what we have been doing. And the one thing that was screaming at me there is community. When you're talking about the physiotherapist and having trust in each other professionally, and then the wider community and the family connections and the sense of place when people are at home looking after care. So community, collaboration, confidence in decision making. So what I was going to ask you, which you just touched upon, is that these are, it's it's a big ask really of a healthcare system to start thinking about things differently. And when you talk about a cultural shift, it's something that takes time, but there'll be people listening to this thinking, I'm on board with this. The people that you've spoken to at these conferences and these workshops saying, I'm on board. Yeah. So what are these little micro things perhaps? What things have you guys been doing to start with that process? Is it just a case of how you interact with your colleagues? Do you, I'm asking you really about practicing what you preach, I suppose.
Really lovely, actually. So I was in the practice the other day and I was in the triage room. So we triage all the patients. And one of my colleagues who's a GP, so qualified GP, she'd only been qualified for a short period of time, was admitting a 90-something-year-old patient to hospital, and the patient really didn't want to go in. And my colleague was but you have this significant issue, and if you don't go in, there may be a risk that it could cause you to die. And the 90-something-year-old and her family were saying, but actually, we don't want to. And my colleague couldn't get past the idea that actually the risk, she wasn't doing the right thing for the patient by not admitting them to the hospital because of the risk that patient might die if they don't go into hospital. The patient understood this. So in the end, I kind of sort of listened to the conversation, and it was literally just after we'd had the workshop, and I kind of said, let's just have a quick chat. I talked to my colleague and said, look, the patient understands the risks. They've got capacity, the family behind them. Let's see what we can do in the community. And it was really interesting because the pathways weren't there to allow me to manage this condition in the community. And it took me about an hour to organise a whole load of stuff with the community people, which otherwise would have taken me 10 minutes to admit the patient to hospital. But it was right for the patient, and it was right for the family. Kept them in their own home. Didn't put a very elderly patient into hospital, which would have been completely inappropriate for them, especially when it wasn't what they wanted. And then actually I had a conversation with the clinician afterwards and said, well, why were you doing this? And it's like, well, I didn't want to get into trouble. I didn't want the patient to die at home and then it be on my head. But also my perception was that was the right thing to do, because I was always taught with the X condition, you always admit that person to the hospital. That was what I was taught. So it's really starting to think about, bringing your experience in. But I think the most frustrating thing in that was actually that the pathways weren't there to allow me to do it easily. So it would have been a 5-minute job to admit the patient to hospital. It took me over an hour to organise everything in the community.
And then I suppose with your professions being under time pressure, and you've always got to think about the next person waiting for you. But then you mentioned by making that decision, empowering your colleague, instilling them that confidence with your experience.
Well, absolutely.
So the hospital bed is now available for someone who needs it. There's one less ambulance on there. And that's the clinical side. You're talking about the humanity of the patient. Yeah. But the flip side of it then is that it's a system that works better.
Yeah. And I think if we had the neighbourhood services in place, it should be as easy for me to admit someone to a neighbourhood service as it should be to hospital.
Is this something you're seeing as well, Claire?
Yeah, definitely. And I think I've been spending some time in acute trust, sitting on board rounds and just trying to feed some of this in. But can this patient go home today, because actually it will help that patient in ED? And then spending time in ED emergency departments, looking at patients who have that decision has been made to admit them to hospital, but just sensitively having those conversations with the clinicians of, what if we did something different? Could we have the hospital at home look after this patient in their own environment? And what benefits would that have? So just trying to slowly, gradually raise awareness of the benefits of this approach.
And I think what we'd like to do is turn this into a more systemic piece of work where we address this with different parts of the system, different levels of clinicians, particularly I think that kind of, not the senior executives and things, but that kind of middle layers, clinicians, supervisors who lead teams, who are there to support people and just say, right, actually, how's this working at your level? Is there ways that can take it back? Instill some of the passion that Claire and I have. And interestingly, a whole load of people, we've kind of, from the workshop, we've seen other people have, and start to embed this message. And then even look at some of the structural issues of hospitals. How do hospitals work? How do community teams work? How do we make sure these teams are working coherently for the best interest of the patient, but also for the best to support the clinician?
Well, look, this is a podcast, so people can't see what's in front of us. But if I could paint a picture, we're sat at a table. There is an extensive collection of notes. We've got printouts of presentations, all kinds of things. So while we are having this conversation, there's an awful lot of work that you have both been doing on this topic. So in terms of resource, things that if people are listening to this and they're really interested and they want to get a fine-tooth comb approach to things or find out more about what's happened in these workshops, the case studies that you've done, what's available in terms of resource for them?
So there's the Senate paper, which I talked about earlier, and we could put the links onto that. We've got a whole note of a whole pack of things we're turning into a learning framework. So we will be able to share that, including a whole pack of case studies. Though, interestingly, we took these case studies to the clinical workshop we ran. We barely used them because everyone there had their own. And that was even more powerful when we used it. So that was really interesting. But we can put that out. There's a number of graphics that illustrate things like the rule of law that Claire brought up earlier. There's some real slogans that we need to bring out there. That concept that the team has your back. That needs to be really integral into it. But also things like, when you're in the community, there's a question everyone should be asking this is I'm thinking about sending someone to A&E, but why A&E? Or if they're in hospital, why not home? Why not today? So we're always asking ourselves those questions. So we can pull all that together, I think.
And we've got a presentation with some slides as well on patient-centred decision-making. So focused on the patient and all the principles that Will and I have spoken about today.
So whether you're someone who is just driving out and about in the community and you want to know more, whether you manage a team and you want to upskill yourself in these things and then pass those learnings and that information onto a wider team, whether you're a decision maker and you want to make, want to sway and influence people within your organization. So we've got resources for you. So how do you get hold of it? So how are you consuming this? If you're using the YouTube link, what I'll do is I'll make sure that the email address is in the description in there. But if you want the resources that Claire and Will have so painstakingly put together on this topic, and this is just the beginning, by the way, we're at the reimagining stage. Who knows how many podcasts are to come on this or where this will take us? The fun part is finding out. But if you want to get hold of all of these resources, then the best thing to do is to drop an email. Here's the email address. I'm doing this bit slowly so you can grab a pen or make a note on your phone. If you go to hw.coms@nhs.net. So that's hw.coms@nhs.net. That's the communications team at the Herefordshire and Worcestershire Integrated Care Board. That's where I'm from. That's where I work. You drop me a line. I will make sure you get all of the resources you need. I can also get you a downloadable version of this podcast as well, so you don't have to throw YouTube links around and everything else. This may be hosted elsewhere in the future, but for now, this is where we reside. And I think for now, we should probably let people get on with their day. So my thanks to Dr. Will Taylor and to Dr. Clare Marley. And thank you for spending the time with us, trying to reimagine risk.